Let's move on to the scapulothoracic. Now this is obviously not a true synovial joint at all, and the joint mechanics are not based on the same principles. What we're actually testing here is, for the most part, is the extensibility of the soft tissues that control the scapular movement. And in very many cases this is a test of muscle extensibility, so we're looking for hypotonicity of the muscle due maybe to a palsy, or hypertonicity due to a facilitated segment. And there may or may not be adaptive shortening on these muscles that need to be stretched. Just lay on your side for me. Okay, stuck?
Yep.
Okay, come towards me this way. Okay, so we're going to look at just moving the scapula into the 4 quadrants. Probably the easiest hold is to allow the patient's arm to hang over your arm like so, and then you can grab the shoulder girdle above and then grab the scapula below here. So we're going to move the whole shoulder girdle. We will be moving it into elevation and retraction, and we'll be testing the protractors and depressors. We'll be testing it into depression and retraction, testing the elevators and protractors, and then moving it into protraction and elevation, testing the depressors and retractors, and then protraction and depression, testing the elevators and retractors. And we're looking really for the range of movement as well as the end fill. Are we getting too much movement or not enough movement? Now, we're not going to talk about this too much, but you have to wonder, for example, if levator scapulae is tight and it's restricting this protraction and depression, what's making it tight? And it's really incumbent on you to start looking in the neck to determine whether or not the problem lies in the neck. But to stretch these muscles out, which is not really a biomechanical technique, so I'll just talk about the easiest ways of doing this, and it's simply to take the muscle into the direction it doesn't really want to go into, and then applying a hold relax technique, don't let me move you, and relax, and then moving it further into that range, and then essentially stretching it into the range that it's not interested in moving into. Now, there are a lot more specific stretches for this region, but in fact it's important that you really get a lot more detailed knowledge on this. So this tape really isn't the place to be talking about muscle stretching. Okay, if we move away from the scapulothoracic joint, we can look at the acromioclavicular joint. And we've got a couple of ligaments that we need to test out here. And those are the bands of the coracoclavicular ligament, the conoid and trapezoid ligaments. Now, the conoid ligament is running more or less vertically from the coracoid process up to the undersurface of the clavicle. And to test this ligament, we will do inferior vertebral border winging. So we'll have the arm either on the patient's side or laying behind them. As I pull the inferior vertebra away, or the inferior scapula away from the thoracic wall, then it's going to tend to push the clavicle in the same direction, downwards. So my stabilization on the clavicle will be to hold it up and back. So that'll be the position there. And I need to come underneath the angle of the scapula and tip it. So if I bring her into this position, and then bring the scapula down over my fingers so I can grab the scapula like so, stabilize the clavicle, and then lift the inferior angle of the scapula away from the chest wall. And we're looking for a reproduction of pain around this area, the point of the shoulder, and also an excessive amount of winging. For the trapezoid ligament, we will pull the the vertebral border of the scapula here away from the chest wall. So we'll be tipping it this way. Again, with the arm in basically the same position behind the back or on the side, we will stabilize the clavicle again, and this time grab hold of the edge of the scapula here, stabilize the clavicle, and pull this the vertebral border of the scapula away from the chest wall, looking for signs of instability and pain around this area. We can stability test the AC joint, doing an anterior and a posterior glide at this joint. So if we get the patient in sitting, can you face that away for me, Nora? Like so. We'll come across the posterior edge of the clavicle here, and we can stabilize around the front of the shoulder by putting the heel of the hand onto the coracoid and grasping the humerus will stabilize the shoulder girdle. The thumb will come onto the posterior edge of the clavicle and will shear the clavicle directly forward. Now the plane of the joint is anterolateral, so to test the stability of the joint it's a straight anterior glide, and for posterior stability we'll simply shift grips and push it back like so. We can test the arthrokinematics of this joint, the glides, in much the same way. We don't really have to change our position very much, just the direction of the glide. So to test mobility, I shall glide it in the plane of the joint, anterolateral, like so, and posteromedial, like so, pushing through my right hand. There. There is some rotation available here. This joint degenerating fairly early in life, it allows some long axial spin of the clavicle. And we can test this by doing protraction, elevation, retraction, depression of the shoulder girdle. Can you lie on your side, face me? So we're going to come back into the same position as we tested the scapulothoracic joint. Come a little closer to me. That's great. Into this position here, and in order to test the anterior roll of the clavicle, I'll bring Nora's shoulder up into elevation and protraction, and then grasp the top of the clavicle so that as I pull this forward it will rotate it anteriorly. So there's the test. At the end of the range we'll stabilize the scapula and just roll the clavicle forward in the scapula. To test the posterior roll of the clavicle, we'll take the shoulder girdle back into elevation and depression, like so, and then apply a posterior roll of the clavicle on the stabilized scapula. So I'm doing this with it. Okay, and grossly what it looks like if I move the whole scapula up and down, and you can see this in this position. So we'll be moving from retraction to protraction. Okay, there's the movement of the scapula, and it's just that at the ends of range we emphasize the roll, looking for the end fill, and the posterior roll here, looking for the end fill. So we've looked at the mobility and stress testing of the acromioclavicular joint. In order to treat this, we can do it in much the same way. If we find that the rolls of the clavicle are restricted, then we can take it into the position that was restricted, much as we did in testing. So for an anterior roll, we'll bring the scapula up and protract it. And this time, instead of simply testing, we'll take the clavicle this way, get firm stabilization on the scapula, and then pull it forwards like so. And we can use a hold relax technique again to get it to the end range, oscillate it, or a prolonged stretch. For posterior roll, we'll take it back into retraction and depression, come on top of the clavicle here, and glide the clavicle backwards, having done hold, relax, and so forth. If it's the arthrokinematic that is hypomobile, we can treat that as well, directly. To produce an anterior glide of the clavicle, one of the better positions is to have the patient lying on their stomach. Come over this way. And if I was to treat the right shoulder, then I would stand on the left side. If I was going to treat the left shoulder, I'd stand on the right side. And bring the arm up into this position, and then bring your thumb onto the back of the clavicle, like so. And then reinforce it either with the other thumb or the heel of your hand. And now, because I'm standing behind and on the other side of her, the glide would automatically be anterolateral in the right direction. Now, most patients, this will stabilize, this arm position will stabilize the shoulder girdle sufficiently so that you can get a good, stable mobilization. In Nora's case, the humerus is too mobile. So what I would need to do there is slide in a sandbag underneath the coracoid and the humerus there, and that makes a much more stable base for the mobilization to occur. But in most patients you won't have to do that. For the posteromedial glide, we can do that in the testing position, that is up in sitting. Face away from me again. Come down a little bit this way for me. Thanks. I'm getting too old to move up and down the bed, so I have the patients move for me. Stabilize the scapula, and come onto the anterior edge of the clavicle and push, and I'm going to be pushing the clavicle back and medially. So with it stabilised, it's that movement, like so. And these glides are so small that you really don't have to worry too much about getting to the end of range with these. We've looked at testing and treatment for hypomobility. Unfortunately, most of the problems arise with instability. And here you're going to have to take up different taping techniques for the acute joints and also a sling, and then treat with modalities to reduce inflammation. But for a stiff AC joint, these techniques are among the easier ones to do. Okay, if we look at the sternoclavicular joint now, can you lay back for me? We have here a Seller joint. It's an unmodified Seller joint, and it's got 2 degrees of freedom: elevation, depression, protraction and retraction. And as at the other end, because the capsule is so lax and there's a thick meniscus, it allows the clavicular spin. So in order to test these movements out, we can test the roll of the clavicle simply by laterally rotating the arm into this position and using the arm as a lever. And I'll flex the humerus across the body, palpating as I do so the sternal notch and the medial end of the clavicle. And I simply roll it across like so, looking for it to move. And in fact, what I'm picking up with Nora is a click as I do it. So there's an indication that there's an articular instability or possibly a slight meniscal derangement. To test the other roll, I'll immediately rotate the arm here and same palpation point and roll it towards me like so. So I can feel that clavicle rolling. To test distraction for the actual joint capsule and looking at the spins, I will test it by walking around to the other side of the bed and then testing on the opposite side. So I'll stabilise the manubrium, gentle stabilisation, nothing too strong, and palpate the medial end of the clavicle with my index finger. And then grasping the lateral end of the clavicle, I simply just pull it laterally, and I can feel the clavicle moving away from the manubrium. Now this test is particularly sensitive for arthritic conditions, and it will really very much help you to rule out muscle as a cause of the hypomobility. We can test the other glides as well here, and we can test an anterior glide and a posterior glide. Slight stabilisation on the manubrium, and all I'm going to do is push this posteromedial and pull it anterolateral, the clavicle. So I'll test its ability to glide forwards and backwards. And the superior inferior glides are not particularly comfortable, and the patient usually won't let you do them, and you really don't gain an awful lot more information out of doing these tests. To stress test the joint capsule, we'll do the same position and the same glide, except again, instead of going along the plane of the joint, we'll go directly anteriorly and posteriorly. But be careful while you're doing these. These joint capsules are not particularly strong to these movements. So just very gently pull it forwards and back as you strongly stabilise the manubrium, and there should be very little, if any, movement occurring there at all. Treatment for this joint is the same as for mobility testing. We can go for pain relief by doing very, very gentle traction, or by increasing the traction and increasing the stability on the manubrium, we can produce very strong traction to stretch the joint capsule. Similarly, if the glides are restricted, then I can come in and basically produce the anterior or posterior glide, depending on which one is restricted. There are the osteopathic techniques for muscle dysfunctions, but in fact, if you've been treating this properly and you've basically ruled out the neck as a cause of problems in the shoulder girdle, then any myofascial restriction should have disappeared as you've been treating the other joints and the spine. But the more common technique to use for the clavicle now, this is really to regain clavicular movement and is not specific to any one joint. The usual technique to use first will be to drop the shoulder girdle back, like so, and you simply palpate for when the clavicle starts to move, and then you do a hold relax technique by don't let me move you. And it's very, very gentle pressure, and actually relaxes. You simply take the shoulder of the humerus further back into extension until you feel the clavicle start to move again, and then repeat this until you get no further differential movement between the humerus and the clavicle. That is, as soon as you start moving the humerus, you feel the clavicle move. And this technique, combined with the articular techniques we've looked at, will clear up almost all of the AC and SC joint hypomobilities. Now, it's after these tests that you can effectively test the muscles. And we're not doing this. This is really part of the tissue tension testing. But we can do isometric contractions to the muscles after we've cleared the other components around the shoulder girdle. The reason that you really can't test them first is because you get an awful lot of false positives from the joint capsule to which these muscles are attached, and also from the SC and the AC joints, and the effect of these contractile tests on these. So the muscular test should really be left until the end of the treatment and examination of the articular shoulder girdle and not the muscular shoulder girdle. Okay, we'll be moving on from here down into the elbow on the next segment of this tape.